microecologic changes which affect the outcome of host defenses. So I say integrative microbiology concerns infections caused by multiple species in which individual species fundamentally alter the growth patterns, pathogenicity, and antibiotic resistance of other species. Now you will notice that this is what would be a good definition of biofilm also. But there is a distinction between, at least in my mind. So let's cover this point, co-infection. The term co-infection is limiting because it does not address the prevailing microecological condition. For example, we say that people who have Lyme disease, they will often have co-infection with babesiosis or ehrlichiosis or Bartonella. So there are a specific number, but the model is the same. The model in the mind is that there is a bug and we have to find a drug. Okay? Now this model of one drug, one bug, one disease, one drug, indeed is very valid. That's not open to question in my mind. So if a child has acute streptococcal pharyngitis or tonsillar abscess, well, you drain the abscess, but you also give him penicillin. So if somebody has tuberculosis, you do the anti-tubercular therapies. So the distinction that I'm trying to draw here is healthy people who get exposed to a particular microbe, they have a specific, clearly definable clinical disease. You have a microbiologic support, laboratory cultures a bug and gives you the sensitivity. So I have no criticism of that model. That's basically Louis Pasteur's model, and I think it's valid. Now biofilm, you can define it as a colony of diverse microbial population adherent to a surface and embedded within a matrix of extracellular substance, some people call it slime, composed of polymeric jumbles of DNA, proteins, and polysaccharides. So now we are going further beyond the idea of co-infection. Co-infection could be a systemic problem. Biofilm, the idea is that there is a surface. On the surface there is community of microbes, but these microbes are supporting each other. They are defending from predators, for example. These phagocytes come in and they will engulf the microbes and they will kill them. But in these biofilms, they create those conditions, and you will see later on that the fundamental change is again the oxygen. Because biofilms are building grease in a different model. Here is not grease being built on a mitochondrial membrane or on a cell membrane or on a matrix. Here you have an idea that some colonies of very clever microbes are cohabiting in a discrete anatomical structure, usually a self-membrane. Originally these ideas came from catheters. When they were catheters, they would have these fungal infections. They were very difficult to take care of. They were not responding to antibiotics. So the idea of biofilm, I think, is a major advance in our thinking, because it sensitized us that you can't place these things. And what would be the commonest example of a biofilm? Coating on the tongue. That's simple. Whenever you see it coating on the tongue, which ancient used to use it, they heavily depended on them as a mirror. Mouth is a mirror of the bowel. So when you saw a coating, that's a perfect example. And now if you culture coating, you will see that there are actinomyces and there are molds and there are some other bacteria. And of course, we ordinarily don't culture for viruses. But if you did, or we don't culture for parasites, we have other ways of looking at it. So I think this is really a great advance in terms of within biofilms, microbes create nourishing and protective environments for each other. These structures protect microbes both from predation and antibiotics. Now these ultrastructures of biofilm have been, I'll just show you quickly some examples. but they are well documented. And you have various types of microbes in various configuration, and some of them will, this is interesting that some microbes, they will go into strand forms or these yeast forms, and that provides a scaffold, so to speak, for the other microbes to come in and occupy the niches created by these things. And down below is the citation where I took it from. Mycotoxicosis disox dynamic. I think this is crucial. The other concept of coming from this integrative microbiology is, so what's the difference between integrative microbiology? In my judgment, what I was trying to say was to advance this one step further and say biofilm knowledge is solid, has been well worked out, and we pay tribute to those people who did this work. But biofilms do not address the problem of microecologic changes of tissues surrounding the biofilms. So the focus on biofilm is on microbes. What I wanted to do was to focus on the host, on the cells which have trouble getting rid of microbes. It's always this eternal dance of life and death between the predator and the prey. And sometimes the prey becomes the predator and the predator becomes the prey. And so to me, it seemed that was very important. And the other thing was in biofilm field was this idea that perhaps we can use multiple antibiotics, concurrent use of antibiotics to cope with this problem. And that doesn't work. They found out that that doesn't work. And the reason that doesn't work is that microbial species A would produce certain substances which will neutralize antibiotics which ordinarily would have killed species B. And now if you have species A, B, C, and D, the antibiotics, even if you brought 4 antibiotics, let's say you broke up a biofilm, and let's say you did a culture, and so you have 4 reports from that, and laboratories can do that. And they would tell you, okay, we've isolated these 4 bugs, this is the sensitivity pattern, so we have these 3 antibiotics, and they will cover. It won't work. Because in real life, those antibiotics will not get into those bugs because they protect each other. They have this slimy cover. And integrative therapeutics to me then would mean that you have to address those conditions not only which lead to biofilm formation, but more importantly, to the cellular ecologic condition which allowed biofilms to form in the first place. So the tongue is clear, but if you get an attack of ulcerative colitis or Crohn's colitis, now the tongue is coated. Or if you get an infection, let's say a person has HIV, is doing all well, but then comes an extreme stress and there is a sinusitis attack and antibiotics for sinusitis, and now the fermenting microbes in the gut overgrow, the so-called yeast overgrowth, and now you have an altogether different problem. So I thought that we needed a concept which goes beyond the biofeedback, and this is my attempt. And you will notice later on that I consider the integrative therapeutics for in integrative microbiology basically oxygen. So you have to focus on what are the things which are interrupting the entry of oxygen, what are the things which are interrupting the utilization of oxygen, what are the things which are interrupting with oxygen signaling, what are the things which are clogging up the oxygen-driven energetics. And so in reality, it comes back to, I mentioned earlier the first time that there are direct oxystatic. Oxystatic means, that again is my term, but oxystatic, there are some people in basic sciences who have used this word oxystatic, but they are referring to, in controlled experiments, they will add certain concentration of oxygen, and if they maintain that oxygen, they would say it's oxystatic. So their use of oxystatic is very different from the use that I am giving to this term oxystatic. I am looking at in a broader say that anything which restores the functionality of oxygen is oxystatic. So it's a homeostatic concept. The single bug, single drug approach usually works well for acute infections caused by single microbe infections. It usually does not work for people with chronic problems. And now I come to tell you something very interesting. We're talking at the break that there have been people before us. There was an Arab, and if somebody in the audience knows that book, I would love to get a copy of that book. I can't. But there was an Arab in their golden time, which was 8th, 9th, 10th, and 11th century, who wrote a book on oral pathology as the basis of systemic disease. This is long before we said, okay, you have strep throat, you get rheumatic fever, okay? And then people said, okay, you have Campylobacter, or you have some other bacteria, porphyrins, these gingival microbes, and they cause heart disease. So this is relatively recent, but long before that, people were aware that mouth is just not an entry for material things. It has much more to do with the health. So I say that integrative therapeutics in the context of integrated microbiologic problems is basically oxytherapeutics. Now here's something interesting. 1998, a paper in Nature, a very important paper. Recent advances in the application of molecular genetics approaches have emphasized our potentially huge underestimate of microbial diversity in a range of environmental conditions. Discover magazine a few months ago had a cover story, and it said there are 30 million microbial species on planet Earth. I don't know who counted them, but let's take one or two less. And then they also made a statement which caught my attention. They said, well, 70 of these have been associated with human disease. How did they figure it out? So the point is, this is a gross error to say that there are only 70. What they should have said were that in the laboratory conditions, in the prevailing model, with our limited ability to culture these microbial species in the laboratory, that's a crucial point. Because the problem is that you can't culture these things. And Mayo Clinic came up with a very important study several years ago that these people who had chronic sinusitis and they were not responding to antibiotics, with special culture medium, they were able to document the presence of mold. The word mold, fungus, yeast means the same thing. So indeed, I believe this primarily as the limitation of the laboratory, the state of the art, as available to clinicians, that we are not able to precisely culture a lot of these primitive life forms. Primitive life form is my term for those microbes which thrived under the primordial conditions of acidity and no free oxygen. Remember I said earlier they used to get their energy from sulfur and nitrogen and carbon. Now at that time, back in 98, I wrote this paper. This is that paper that I was saying, Oxidative Regression to Primordial Cellular Ecology, that's abbreviated as ORPEC. And I propose that under certain conditions, the normal oxygenative cellular ecology undergoes an oxidative regression to primordial cellular ecology. That means all bets are off. So all our ideas of acute microbiology simply do not apply once you change the condition. Now this is interesting. We were in Toronto. I think it was 1997 on Bloom Street. Those of you who are from Toronto. So my host was driving me, and she was pointing some things. And this is how when you're obsessed, you have 2-3 dialogues going, one with the host and one with yourself. So, or two with yourself. So I don't know what I was thinking was, and I was very politely thanking her for pointing out all these wonderful things, and it was a very nice day. And at that time, it came to me as a flash, because somebody in the conference that I was talked about underlines ideas of pleomorphism. And I had never really seriously looked into this issue of pleomorphism. And I wasn't interested in this Pasteur and Béchamp debate. And Pasteur became very successful because that's where the money was, chemistry, drugs. And Pasteur got no place because he, like us, was into the host conditions And people who focus on host conditions, usually money doesn't like them too much, okay? So the money runs usually to people who focus on the bugs. So, but at that time, unknown to me, I found out that Nature paper later on, and I wrote this paper and we talked about this primordial, and I knew that nobody would read this article, and that will be the end of that, but I had to get it off my chest. In the orpic state, progressive acidosis, oxidosis, and clotting, unclotting disequilibrium create conditions of respiratory to fermentative shift in ATP production that I just mentioned. I think I'm going in the wrong way. Okay. This is just a repeat of what I said, but this repetition is probably not very irksome. This is the central part of the program, and I'm just going to quickly go through this because I've covered this before. This term primordial life form, I was looking for a form. I didn't have taxonomic information available to me. I didn't have the genetic sequences, and I didn't want to call it yeast because I had no basis of calling it. So at that time I said, since the characteristics of these cells, now I'm talking about both the bugs as well as our own host cells. So the central idea was this, that bugs are altering the conditions of the host cells and the host cells are altering the conditions of the bugs, back to Charles Robert Darwin. Okay? It's an ecologic constant adaptation which is creating this problem. And for lack of a better word, at that time I introduced this term, primordial life forms, or PLFs. And this is some of the early work that we published where we were looking at, I mentioned Bob Bradford. He and I did a lot of work together in those years, and he helped me clarify a lot of things. Let me pass quickly because most of you know that. This is a normal picture. These are platelets, these are red blood cells. Most importantly, if you look at the background, you don't see any clots, and as you go on, you begin to see these black and white bodies appear. The black bodies, you're never sure whether it is platelet clumps, but these white bodies, clearly there is something growing up here. And then if you follow them, they will start growing, and sometimes they will grow very much like fungi. And if this goes on, then you will have clusters of these things, black and white bodies. At that time, we did some serologic tests. And actually, we did publish a paper, Bob Bradford and I, using an anti-candida antibody. We showed that some of these microbes indeed are candida, and you can stain them. And at that time, I also, maybe a few years before that, I had realized that heart disease is really the beginning of these plaques in the circulating blood, which completely alters the whole idea of cardiology. I never criticize acute cardiology, but as long as they are not looking at these things, this would be the evolution of the disease. They are very good at crisis management, but unfortunately in their model, they're not very interested. This is a fantastic set of pictures, so I want to spend a minute with you, show you. You have this big cluster of primordial life forms, some black, some dark, and there are these three phagocytes. And we were in Kenya, and so there was this image that there is a buffalo, and there are these three lions, and they're trying to attack. And then if you notice 2 or 3 minutes, it's the same frame, that this guy comes closer, this tries to go to the tail, and this lion, as often they would do, they will grab the neck of the buffalo and try to drag it down. So there was a kind of an imagery in my mind that, okay, that's what they want to do, that's the next stage, but then something amazing happened. After 2 or 3 minutes, this phagocyte changes, this predator changes its position, and this also changes its position. It backs off. It is as if this patty of hamburger is toxic, doesn't want to eat it. Okay? Just imagine their intelligence, that there are these single cell phagocytes, and they will go and try to bite off. Their job is to clear all this junk and eat up these microbes. But when this is what I mean, in this eternal life and death dance, sometimes the predator becomes the prey and the prey becomes the predator. So this was an amazing, and I happened to catch all these pictures. So now a few minutes later, all three decide this carcass is dead. It'll kill us. So they all walked away from it. Now here was an example on the upper two frames where the bugs came in, and then they invaded the phagocytes, they multiplied within the body, and they killed it, and they disintegrated it, and they multiplied. So these were the observations which forced me to think that this role reversal which is happening, there are larger issues here than just looking at a bug and talking about an antibiotic. And very simply, those are the three things. Sometimes with my patients, I do this, and you may want to sometimes try it too. Whenever I see someone with chronic problems, complex, the usual stuff, 8, 12 different type of diagnoses. I've done endocrinologists, I've done pulmonologists, I've done rheumatologists, I've done this and that. And then I said, okay, you're finished with your ologist, so let's now do something serious. Okay. So I offered them a thought experiment. In my thought experiment, diseases don't descend from Mount Olympus and they don't come out of Atlantis. We are left with really 4 things. We're left with genes, foods, environments, and thoughts. Since there is no treatment available for genetic disorders at this time, as I said earlier, you just blame your parents and disempower yourself. So let's get rid of genes. You're left with really 3 things. And I haven't figured out another cause. And one time we were at a group, and there was a doctor talking about a good friend of mine, but he didn't know I was there. I just joined later on. I was sitting behind him, and he said, Dr. Ali has this oxygen model, but there are other models. And I said, I should really pay attention to this because I can't see anything else. And indeed, if there are other models, I should be aware. He was talking about consciousness, etc. Then within a second it came to me, who came first? Consciousness, brain cells, or oxygen? So I said, I'm back to square one. Oxygen drove the evolution, so we became multicellular, we became very complex, we developed a brain, we developed a consciousness, and now we have a problem with consciousness. So clearly oxygen came first and consciousness, human consciousness came later. So back to square one. These are the major issues. Mold allergy. Mold allergy, I think, is the beginning of many, many problems, and that leads to mycotoxicosis, toxic metals, synthetic chemicals, polymicrobial infections. Mycotoxicosis causes dysox, which in turn increases the degrees of mycotoxicosis. This is a study out of 75 patients. I call them dysoxic. Once I have Krebs cycle results data and I know that I have biochemical basis of establishing the presence of dysox, then, and as I said, I don't try to break them into other. The point, look at this here. The IgE, keep going back. IgE here, the most common out of 75, 73 had penicillium, 71 had mucor, 69 had aspergillus, Alternaria was 69, and actually Candida was number 5. Now on the IgG side, they were much higher titers, which means that IgG mostly is a protective antibody. IgE, E for evil, causes problems, and IgG very often blocks it. And indeed, the basis of immunotherapy, one mechanism of immunotherapy is that you cut down the production of IgE, you increase the production of IgG, the so-called blocking antibody, and there's really a very good correlation. Many years ago, we published papers in American Journal of Clinical Pathology when I used to write for the mainstream journals, and we published a lot of data showing excellent correlation that when you can induce strong IgG response, it correlates with clinical response. And in those situations, for example, chemical sensitivity people, they will not give you a very strong IgG response. You can't also, unless you take care. Chemical sensitivity, to me, is a problem of the liver, and the guardian angel of the liver is the bowel, back to square one. And the guardian angel of the bowel is really your philosophic and spiritual equilibrium, and that creates that sun soil model. Bowel, blood, and liver is the root system, soil. Thyroid, adrenal, pancreas are branches. Neurotransmitter, your hormones, your hair, your eyes, your skin, that's like flowers and leaves. And to complete this sun soil model, the gardener's way of looking at human health and disease. So the sunshine represents spiritual and philosophic issues. Now this next slide is also very interesting. This looks at now the individual mycotoxins, and I wanted to correlate also with hippuric acid, unquestionably the most sensitive indicator of liver injury. So when people are on statins, for example, and you do your standard liver test, AST, ALT, very often they will not show you, sometimes they do, but very often they won't show you the problem. But those people who are taking statins, if you do the hippuric acid test, most of the time actually it would be up. So there is clear objective biochemical evidence that there is a problem there. But in our patients then, arabinose, it happens to be, arabinose directly ruptures Krebs cycle. And to tell you the half-life of these mold toxins, in funerary palaces in Egypt, there are some, wine dried up, they're white containers, and there's a little yellow deposits, and they analyzed it, and there's tartric acid in it. So the life of these mold toxins can be into thousands of years. And just to say, the rest you can see, these furan compounds are also very potent toxins. But I think the big problem is really arabinose. Tartric is also a significant problem. Let's go on to the next. The bowel-liver relationships, I just briefly mentioned to you the model that I described. This book, if you are interested really, this book gives you, this is the first edition, but this gives you a very good overview of people who want to have light reading at the same time they get the hard science. So this was written for general public, but the hard science is there. I just try to soften the words, and I try to make it a little bit more agreeable to the general readership. Now, this is what happened on Bloom Street in Toronto. Okay, I had listened to this lecture on pleomorphism, and I hadn't really studied the subject. So I'm just listening to them, and I'm just thinking about it. What does this all mean? And there's a chapter in this book. Interesting, when I wrote that chapter, I knew it was important, but I didn't know then it would be almost 11 years before I would turn this simple into the model of integrative microbiology, which again means that acute infection caused by a single microbe or by 2 or 3 microbes, that's a different ball game than in infections in chronically ill people. That's why the so-called chronic Lyme disease, the so-called neural Lyme, all these things go on. I have a great deal of difficulty because people just don't get better with antibiotic therapy. They will get better if you integratively restore the entire system, and then vast majority of the time, except people who are impossibly angry. Angry people, it's chemistry of anger is so easy to understand. Too much adrenaline, too much acidity, neurotransmitter turbulence, and then anger feeds upon itself. If there's one thing about human condition, it's the basic addictiveness. If you're not addictive to gratitude, please know that you'll be addicted to anger. It's really that simple. And we in America are suffering. If you send me an email, my email is just my name, md@AOL. Or you can Google my name, or you go to the center. I hope that you will go to the Ethics in Medicine, and there you put in your email, and then you will regularly get those things from me. But I did not know at that time where this chapter would take me. Oxygen settles the great Pasteur-Béchamp debate. When oxygen metabolism is optimal, Pasteur's microbes from outside play more important roles in causing disease. When oxygen metabolism is dysfunctional, Beshamp's life forms multiplying from within the body become more important. So these PLFs that I was showing you, that's actually what Underline should have gotten 2 Nobel Prizes. One, he talked about the sexual reproduction of microbes. And what was his name? Joshua Lederberg. Joshua Lederberg from Rockefeller, he got his Nobel Prize 30, 40 years ago because he characterized sexual reproduction among microbes. But if you look at Underline books published in 1915, he has a chapter where a whole chapter about sexual reproduction. But this is what happens. You know, a lot of these important discoveries. Who discovered oxygen? Anybody wants to take a guess? Who discovered oxygen? Huh? Joseph Priestley. Yes. Anyone else? Yeah, that's what it is. If you look at encyclopedia, when I went to med school, Joseph Priestley, the English clergyman who was a great scientist, they burnt his house and he immigrated to America. And when he came here, they told him his friend Lavoisier in France died. He was guillotined. You know that story. I try to put my new information on memory hooks of old information. This is a trick which works very well for me. So when I learn something, I keep thinking of what else I know so I can hook it on to. So I always related Joseph Priestley and discovery of oxygen to the Revolutionary War. In reality, it was Michael Sandovigius, a Polish chemist, who heated niter and he produced oxygen. He didn't call it oxygen at that time. Lavoisier called it oxygen. And he was at the time of Jamestown. So now in my mind, the discovery of oxygen with the time of Jamestown and Joseph Priestley, who characterized certain things, that's revolutionary time. Incidentally, I might tell you that one of the friends of Sandovigius, it's an amazing story. Sandovigius' book was accidentally discovered by a librarian in a Warsaw library. And so there somebody was looking and they said, what is this? This is what Joseph Priestley did in 1773, I think. But Sandovigius did it about 170 years before that. And one of his friends who was watching that, he said, this is interesting because Sandovigius had showed that if you heat niter, you release this oxygen, air at that time, and plants grow very well, and bugs in it survive. And if you create a vacuum, the bugs die. So they had this idea that there's something in the air which is essential for life. So Sandovigius' friend came over to England, and he said, he was some kind of an entrepreneur. So he said, let's build a submarine. So the story goes, and it is actually very well documented. It was documented later by Boyle of Boyle's Law, the Irish guy. So he dug out all the clippings of the London newspapers of that time, and apparently it was 1621 when this guy built a wooden submarine, and he produced cylinders of oxygen by heating niter the way Sandovigius' friend had done. And the sailors were, of course, breathing from these bottles of oxygen, and it submerged, and it went for about 2 or 3 years, and King was in the audience, King James. Okay, that's just a historical footnote. But this is very important, that what we are seeing PLF right now, I showed you, is actually what Bechamp was saying that. This is what Underline was saying that. The second Nobel Prize, Underline, the first Nobel Prize was that he talked about sexual reproduction of microbes. The second Nobel Prize that he should have gotten was, he described that clot formation in the blood that later on a lot of other people did. Bradford did, we published a lot of data on it. But in reality, if you wanted to acknowledge the seminal contribution, it was back Underline. And I don't, maybe I don't know enough about it, I haven't really seriously looked into this, but I am not, let's say I am very uncomfortable with a lot of the claims which are being made on names of Underline. But I think Underline, was not a doctor, he was a zoologist. He couldn't get a job. Okay, after the war he couldn't get a job after World War I. So they needed a doctor to run their hospital microbiology laboratory, and there was no doctors available. So somebody mentioned it to Underline. He was a zoologist. So he was a zoologist from a zoo. He came over to run their laboratory, but he was a very productive person, a very ingenious person. All right, that's my website, those of you who want to sometimes visit it. But this is what I really would like, and I hope that you would test the castor oil I mentioned, 5-cent treatment. You will test hydrogen peroxide, 5-cent treatment. I hope that you will teach breathing, feather breathing. If you go on this website, and I posted, this is quite remarkable data, that we had 232 patients. Our criteria was we wanted to come up with the simplest way, which in a busy clinical practice can be taught to a patient within 10 minutes. So that was our criteria. And so we had some parameters. That's a different subject. But I would suggest that you go onto this website and try to look at that. We call it autonomic breathing test, ABT. And the beauty of that is it gives you objective, measurable results. It's something that anybody can teach to a patient. It's something that patients can do at home, and they can come back and they can tell you that the best way to, solving problems of blood pressure and sleep and stuff like that. A peculiar aspect of Pasteur-Béchamp debate is that the leaders in Béchamp's camp, Béchampists, have been passionate microscopists, while Pasteur's disciples, Pasteurists, have shown little, if any, inclination to use their microscopes to study the pattern of microbial growth in the blood. Isn't this fascinating? That infectious disease people have no idea about it. The reason is they don't take the time. I'll tell you an interesting, forget about this material, let's have some fun. So, here I was a chief pathologist, and I had been there, so I got elected as president of the staff. So I was considered as one of the senior citizens, and they would let me go on with a lot of shenanigans. I would finish my pathology work 1 hour, and then I had the other day, and they would take me a lot of these hospital meetings, and so I used to write my paper, and that's what I, used to do. So once I decided that I've diagnosed enough cancer, I'm being suffocated, I need to reinvent myself. So I figured the best way to reinvent is I start a new life. So at that time I came out, and I was all by myself. But I wanted someone, serious-minded doctor, to look over my shoulder and say, hey, you're playing with people's lives. Because it's very difficult, it's very easy if you're very passionate about your work and you want to walk that extra mile. I'm glad I got out of surgery. I'm pretty sure that I would have ended up in some prison someplace. Because with mine, I would have constantly experimented, and I would have killed some people, and I would have ended up there, okay? So fortunately, I left surgery, and I went over to pathology. Now I go to clinical medicine. I have no idea. I've never taken care of people in America. So, but there's a very important point here. That's why I'm digressing. So my associate, Dr. Fahmy, I mentioned he's professor of pathology at Mount Sinai, and he and I were together 30 years in the hospital. So I said, Al, couldn't you come in and just work a few hours in my office? I'm doing these things, and I don't know what I'm looking at, but I want a serious-minded person. And he said no. And we had another pathologist, Dr. Judy Juco. So she became disabled with chronic fatigue. So that's how somebody told her, well, why don't you see him? Well, fortunately, she got better. And then after about a year, I said, Judy, could you give us a little time, be a part-time doctor? Judy Juco has turned out to be a world-class integrative doctor. I mean, she is the anchor of our place. And she's also very method type of a person. I go off the handle, and she says, no, we need an ultrasound of this ovary. So that's very important. But here's what why I digressed. It took me a year to convince, Dr. Juco is also a pathologist. It took me a year to convince her that these microscopic things that we are seeing, these are not artifacts. Because we had to see healthy people, we had to see sick people, we had to see sicker people, we had to see very sick people, and it correlates with the population of these things. Then we had to treat them, And then when they got better, then there was perfect correlation. Well, when I say perfect, I'm talking about something like 90-95%. I shouldn't say perfect. But the point is, there was a compelling correlation. Sicker they were. For example, people who were taking chemotherapy for cancer, they had the dirtiest blood. They had the heaviest population of these things. Now, when we did a lot of work for them, then eventually they became stronger, they were feeling better, they didn't have this tongue or whatever, the fever blisters, canker sores, and it correlated very well with the state of the blood. And so when the state took away from us, Dr. Juko was the first person to say, she says, you know, I feel I've lost my right arm. She says, how do you feel? I said, no, I don't want to tell you how I feel. I'm so rabid. Dr. Fahmy, it took us almost 6 months before. Now remember, these are university pathologists. These are full-time microscopists. I think it's one of the great ironies that the influence, the people who make the decisions at a societal level, at a government level, at a money level, have absolutely no idea. They don't have the courage to take a drop of blood, put it in a microscope and see. And so I come back to this, that the Béchampist, you know, we are kind of the successors of Béchamp, his ideas of holism, relationships, and Pasteurs are our infectious disease people who, if they don't have one bug, you know, they're kind of paralyzed. I don't think I'm being ungenerous, or maybe I am. Okay, Béchampists used their microscopes with great care and persistence. In clinical medicine, they focused on changing the internal conditions of the body. The Pasteurists, by contrast, completely neglected issues of blood ecology and committed themselves to killing microbes with chemicals, which, as I said, is God sent for limited acute infections. So my comment should really not be taken as derogatory of the work of infectious disease, as long as they're working with specific bugs in people who otherwise were healthy. Otherwise, if people are unhealthy, that approach is not enough. Canker sores, what's the price? I'm going to ask you, in the interest of saving some time, that if you would please visit this. There are 2 articles which are of special interest to you. One is this canker sore, I mean those of you who are in dentistry, and the other is burning mouth syndrome. And I think you will find that these 2 articles, again, I'm looking at the problems through the prism of oxygen, and I do want to give you some information about what this you have covered, so let me. In 1959, my professors taught me 2 things about canker sores. The cause of these painful sores in the mouth is unknown, and second, there is no effective treatment or preventing or treating canker sores. And it's very interesting. In 2009, 50 years later, my pathology and internal medicine textbooks also teach me 2 things about canker sores. One, the cause of these painful sores in the mouth is unknown, and second, there is no effective treatment of preventing canker sores. And that's just one example of illustrating the importance of this integrative microbiologic model that I'm trying to present, that 100 years from now, if they stay in the old way of one bug, one drug type of a thinking, they will still be writing about, and they will still be writing 100 years from now, the cause of insulin resistance is not known. Why it's not known? Because you don't have the courage to think beyond what the books are saying. In 1959, my professors laughed heartily at the notion that tongue coating can tell much about the state of the bowel. I would introduce the term bowel ecology 21 years later. Of course, I had no idea at that time. And the professor showed nothing but disdain at the thought of bowel detox. See, the way I was brought up, the bowel detox was serious-minded people were not allowed to think like this. What is this nonsense of bowel detox and liver detox and blood cleansing? I was saying, I think to Don, and we had a breakfast together, that in a very perverse way, this field has 3 powerful friends. In a very perverse way. One is global chemicalization of human habitat. 2, global over-angerization. I wanted to present a couple of more of my short poems about this because you can't see all these things happening and be immune to it. And the third thing, of course, is do you know how much carbon imprint is when you have a big hamburger versus chicken? I didn't know that. Did you know that if you have a big hamburger, the carbon imprint of that is 1.7 kilogram of carbon dioxide. Kilogram of carbon dioxide. Just imagine how much. Fortunately, Earth had its lungs. You know, the forests? And of course, we are amputating Earth's lungs. So the madness of the human species is beyond comprehension, what we are trying to do. So chicken salad sandwich, how much, what carbon imprint does it have? It's about 1/4 of that. All right, so you won't produce 1.7. That's really amazing, 1.7 kilogram of carbon dioxide. You know, carbon dioxide is very light. And ordinarily, carbon dioxide is what, 0.04% of ambient air. But what had saved human species all this time are our forests and the trees and the brush and the shrubs. And that's what we are wiping out. We're basically suffocating. Human race has chosen to allow a very small number of demented people to suffocate the species. So in my view, this is a little protocol that we use for our patients. I will present it to you, and those of you who found other things which work better, I would like you to send me an email, and those of you who have not tested it, you might test it. Actually, you know who put me to this was a dentist, and he said that I have been treating I've been giving antibiotic gargles to my patients with gingival disease for the longest time. So when I came to clinical medicine, I said, well, let's try it. So for canker sores, lichen, leukoplakia, chronic gingivitis, glossitis, burning mouth syndrome, dry mouth syndrome, jawbone loss, osteonecrosis, or, you know, that's misspelling there. So for all these things, we have a little program that we use. Maybe I will just explain that to you, and then we can look at the pictures. Dr. Juko, my associate I mentioned to you, she was telling me last week, she said this sesame rinses is an amazing thing. Most of these mold toxins and these bacterial toxins and these mycotoxins, or even the viral endpoint in the mouth, they're really fat soluble, most of them. So at a very simple level, you could say that if you're going to bring a robust rinse with the oil, it's going to take in the mouth a lot of stuff out. That's just a mechanical thing. But I think sesame oil has some antibacterial. There are things in the literature. I have not tried castor oil. We've tried mustard. We've tried sesame. I would not try calendula oil. Calendula oil, you know, if you're going to try that, topical application, be very conservative on it. It can cause some pretty bad problems. I'm sorry, not calendula. I was talking about oregano. So I take back what I said. It's the oregano oil that I have seen some very serious problems with heavy topical application, not calendula. Sesame in our hands. So Dr. Juko was saying, he said, what is it about this sesame? And I said, well, I don't know, except that it works. And I have seen personally, it has been extremely valuable to me for my own, you know, gingivitis. I used to have big problems. And she was saying the same thing. She said on 3 different occasions, this gingival inflammation responded beautifully to sesame. So you take a teaspoon of sesame oil the first thing in the morning, and as you're doing other things, you're using toilet or whatever, you just robustly rinse and then spit out, and then take a little water, rinse and spit it out. So sesame oil rinse, if you've not tried it, please try it. I think for gingivitis, for glossitis, for canker sores, extremely valuable. Now the second thing that we find very useful is we give them antibiotics. We can give penicillin, we can give ampicillin, we don't try to give tetracycline. But the point is, you take, let's say you have, if you're going to try Zithromax, you take just 1/5 of a pill and you crush it, and it will be a suspension, and you gargle with it and spit it out, gargle and spit it out, gargle and spit it out. And you can all do that while you're doing other things. It's not that you are standing on the sink for the next 5 minutes. So we will rotate these antibiotics. That's the second thing. The third thing is really very simple also, which is doing baking soda and peroxide toothbrush. You can do toothbrush with neem. That's pretty good. So that is the combination that we do. And of course, if somebody has a lot of problems, we'll ask them to do it. Why? The first thing, sesame always has to be the first thing. Then you can do, your brushing you can do after your breakfast, and that could be with peroxide baking soda or with neem. There are other natural things that you can use, and then the antibiotics. This combination in our hands seems to be quite good. So this tells you morning what you do. I just explained that, so let me save some time. You can do the same thing after lunch and after dinner. So burning mouth syndrome is very interesting. All these things fascinate me because I already know I'll go to Wikipedia or I'll go to encyclopedia, go to pathology textbook. It's always the same thing. We don't know the cause. Two distinct neural abnormalities of burning mouth syndrome have been described. First is reduced activity of the sensory nerve for taste. That's the chorda tympani nerve. And of course that means that people who have burning mouth syndrome, they will lose their sense of taste. The second thing, which has been pretty well documented, there are these sensors and they're complicated computer models. There's someone in New Jersey Medical School who's very good at it. They published several papers. And so this is taken from his work. And the second abnormality in the burning mouth syndrome is increased activity of the sensory nerve for pain. And of course, that's lingual nerve. So I was reading this in my dentist's office. So I said, okay, if it is valid, it has to be compatible with oxygen. Okay, that's my disease. And if it's not, then I have to think more. So I said, I wonder how I could possibly come up with explanation of these two things. Again, looking through the prism of oxygen. Well, parched mouths do not taste food well. That means taste receptors work only when there is enough water. So in chronic oral dehydration, the chordotympani nerve taste pathways are, I guess there's a misspelling, underused and so become underactive. In other words, in dry mouth, there is not enough water and you are not going to be using your taste receptors, and eventually it will not work. And so you lose your taste, and that shows up as chordotympani underactivity. But now we have the second part, which is what causes the pain and the overactivity of the lingual nerve. On the other hand, all oral toxins overwork the lingual nerve pain pathways, and so they become overactive. Perfectly logical explanation for taste nerves underactivity and pain nerve overactivity. So what they were saying is that in burning mouth syndrome, we have underactivity of chorda tympani and overactivity of lingual. And once you start thinking in terms of ecologic conditions and dimensions of acidity and free radicals, it's so easy to understand that. There's no reason to say we don't know the cause. The bowel-mouth dynamics, you can tell I'm obsessed with this. Oh, this is that picture that I was telling you, the sun soil model of health and disease. I think, why don't I stop here and we can have some questions? Don? Yes. We use a lot of ozone, and you can ozonate water, you can ozonate olive oil. Apparently, ozonation of olive oil does have some technical things to it, which I don't understand. Ozonating water is really a very simple thing. There's a company out of Shanghai. We are trying to see if we can, order a bunch of those things. But they are down to, I think, about 120. So for $120, they will produce a very small size. It's like iron, very lightweight. So I was looking at that. I said, that's a godsend to us, because there aren't any ozone generators out in the market which patients can buy that for use at home. So I think this technology is going to improve. And if you send me an email, I'll try to send you the address of that company. They don't have too many service reps here right now. But the point is, ozonated water is good. We use ozone intravenously also, and there are a number of ways. The safest way that I could come up with and the quickest and the safest, straight ozone into the vein. But this is how we do. Let's say I take 60 cc's of ozone. I'm going to draw a little blood and mix it. It becomes pink, patients like that. But actually I'm going to use the ozonated blood as a way to regulate the flow so it doesn't go. The first ozone injection that I ever gave was to myself, and I got healthy respect for this substance called ozone. I got almost tightness in my chest and I coughed for the next day, and I said, oh, you have to be very careful. But now we are very careful. If you give it slowly and gently, that doesn't happen. So we haven't had any problems with ozone for quite a few years now, because I think people who do that, they're very experienced. But this simple technique of drawing, let's say you draw 10 cc's of the blood and turn the syringe upside down. Now you're injecting it back, but the ozonated water blood will create a little column. When you are injecting ozone, it's colorless. You can't tell at what speed you're giving, because you can't go by the whatever that word is, plunger, piston or whatever, because ozone gets compressed. So that's not a good way to monitor the flow. However, if you create a column of the blood, and so what you do is just by turning the syringe up and down, ozone is heavier, and so it's, well, in the blood ozone is lighter. Ozone is heavier than air, but ozone is lighter than the combination. So that's how we do that. And the first time we always take good 15-20 minutes. The second time we may do it 12-15 minutes. I think intravenous ozone, but my first choice, the only time that I take ozone myself is if I have cold and if I don't have an hour and a half to take peroxide. Peroxide, and the details of all this are on our website. Peroxide infusions in our hands work better than ozone. And I think one reason is that ozone is active form of oxygen, hydrogen peroxide is active form of oxygen. Ozone dissociates much faster than hydrogen peroxide does. But this is just a speculation on my part. I think one other reason is that ozone, again, in our hands. I'm emphasizing the word in our hands because I think that different groups can learn to produce excellent results by approaches which philosophically will take you to the same goal, but they follow a different path. So the hiking trail is different, the mountaintop is the same. So, but in our hands, hydrogen peroxide, we favor that much more over ozone. Maybe in our hands, in our center, for every 15 hydrogen peroxide infusion, we get only about 1 of ozone. So to answer your question, ozone, and I would experiment with it. I would try different. I don't think anybody really has looked at what ozone might do to mustard oil or sesame oil or castor oil, especially if you're thinking of topical applications. Okay, next question. Yes, sir.
I recently read an article about the doctor who wrote about oxygenating each cell at a time, and he recommends that you can do it by exercising with oxygen. Are you familiar with that?
I think the idea, Russians have done a lot of, this is interesting. Russia has no money, so they have to use their common sense. So no, this is true. A lot of good research on oxygen has come out of Russia, and Russians have been trying to do this. The idea of taking oxygen, doing exercise, I think it's a very good idea if you can find a practical way. And when our patients have chronic fatigue, fibromyalgia, difficult problem, cancer, chemotherapy, we give them actually nasal oxygen 3 liters per minute for 1 hour at a time. Okay? Listen, don't underestimate the power of slow breathing. I think as a society we overbreathe to breathlessness. I think subclinical hyperventilation is one of the dominant problems of our time. If you go into that, ethics in medicine, I posted an article on ABT test, autonomic breathing test. There is an example of a gentleman who had emphysema, congestive heart failure. They wanted to do surgery for, take out the non-ventilating part of the lung at Columbia. But in the end, they decided he's too sick, we can't do that. So he came over, and I think 4 or 5 months apart, he has this oximeter. So he's on oxygen all the time. So I saw him, and I thought that if he could take him off oxygen, maybe 1 hour twice a day, that would be good, because continuous oxygen is really not good, because it takes away from the drive from the respiratory center. And he didn't want to hear about that. He was deathly afraid that if he stopped nasal oxygen, even for 1 hour or 10 minutes, he will die. And we had the IV running, so I thought we could intervene. That data everybody should look at. It really will open your eyes, because when we took the oxygen, his oxygen saturation came down, his pulse went up, his blood pressure dropped. And so obviously we are very nervous about that. But I said, let's do just 2 more minutes. And then the miracle happened. His pulse came down, his oxygen saturation came up, his blood pressure got stabilized. Then I said to him after about 10 minutes, would you let me do this one more time? It's very important to me. He knows he's an intelligent person. He knows he's a guinea pig, but he's just going along with me. And we did the second time, and the paper gives you the results of second time. And then we did a third time. That was the first set. And then 5 months later, we repeated this. It's such revealing data. It tells you the power of slow breathing. What happens when you overventilate? Did you know? I didn't. I did, and I didn't, and then I relearned it. Carbon dioxide crosses the lung, blood, air space, pulmonary membrane, at 21 times the speed of oxygen. So now, if you're breathing faster, carbon dioxide shoots out, oxygen has trouble getting in. Now, if you're going to breathe faster, when your carbon dioxide level goes down, that causes vasoconstriction. Carbon dioxide is necessary for keeping the caliber. So right off the bat, you are causing vasoconstriction, less blood, less oxygen transport. But it's more than that. You have a tidal space, you have a dead space. You know, when you breathe in and out, there is a dead space. And ordinarily, the dead space is only, I think the tidal volume is about 500 cc and dead space is about 150. Each time you breathe in, under ideal condition, you breathe in 500 cc's of air and breathe out. But 150 is in trachea and bronchial lodge where there's no exchange. So in essence, you are really using about, well, 1/3, a little bit less than 1/3, let's say 25 to 28%. If you breathe 8 times per minute, and if you breathe 16 times per minute, I'm just telling you the numbers, and you will see the data for 232. We have a little clever, that was a very clever idea, if I can congratulate myself. I was interested in figuring out a way to create an impact of self-discovery for the patient. I wanted the patient to know, what is it that I'm doing here? So we said, okay, we will take your pulse before and after. We'll see the pulse difference. Let's say if a person's pulse has 90, which is not unusual in people with a lot of anxiety and other depression problems. Now, we drop it down to, let's say, 76. Well, between 88 and 76, there's a difference of 12. Now, you have to multiply it with 1440 to come up with the total number of heartbeats saved in one day if the person was breathing at the slower rate. That comes to something like 17,000 heartbeats. And if you bring someone down from 90 to 70, which we often do, you're saving something like 25,000 heartbeats a day. And heartbeat energetically is very expensive. When patients see that, that sells them. So I say it's your choice. You can overbreathe and overwork your heart and die sooner. Ancients used to have a saying that we can breathe less and live longer, or we can breathe faster and die younger. And I don't know how did they figure it out, but I guess they had their own ways. But the point is, it doesn't stop there. So one level is that you've lost a lot of, if you're breathing 18 times, you are breathing 18 times plus 150. That's the space that there was no air exchange. So that's factor one. Factor two, when you blow out carbon dioxide, you cause vasoconstriction. That's less flow. Number three, remember hemoglobin oxygen dissociation curve? So when you have alkalinity, the hemoglobin oxygen dissociation curve shifts to the right, so the oxygen that your hemoglobin is carrying cannot be delivered. This is all something that we learned in first year med school. Of course, we were never taught how to use this in our practices. Now go back to now delivery at the cell membrane, capillary membrane, the same thing at the capillary membrane. Less membrane, less oxygen, less transfer. Now you go over to the cell membranes outside the endothelial cells. The same factor applies there. In essence, what you are doing is, when you hyperventilate, you're breathing more, building more grease, you are letting less oxygen go in. You're really disrupting the entire oxygen signaling system. To me, it is amazing that so many people are hyperventilating all the time. It's not unusual for us to see a starting pulse rate of 84, 88, 92. And then 30 minutes later, you want to talk about national health? You really want to talk about the savings? I'll give you an example. I'll give you two examples. And you have to bear with me, You are what you are. You can't change. Even though I said, oh, this is an international conference, I have to be serious. I can't be my usual self. I can't talk nonsense. I'm doing exactly that. So Canadians, please forgive me. All right, I want to tell you two amazing stories. A woman comes in, and her husband is sitting. She's a very strong New Yorker, very well-read, goes into museums all the time. So she is trying to impress me, and I'm duly impressed. And her husband is watching all this, and he's trying to figure out whether I'm really impressed or I'm just pretending to be impressed. So anyway, this thing goes on, and then after about 15, 20 minutes consultation, I'm sure most of you are like me, but I make my intuitive judgment call. You see, those of us who practice from medicine here, we don't hear. One time Roger Truby asked me, he says, you're doing all these things and writing, and you were at Capitol. How do you focus on patient? I said, I don't. That's the whole point. I don't need to focus. Those of us who practice here, we don't focus, okay? We observe, and then a voice comes, and we do what the voice says you do. So anyway, now she goes over to the examination room. I see another patient. I go there. I look at the blood pressure. It is 230 by whatever, 140. I said, we have a problem. We have choice. Either you help us lower this blood pressure with breathing, some water, protein drink, maybe a little Hawthorne, or I have no choice. This is the first time I meet with you. We will have to ask you to go to the hospital. And then I have no choice in New York City. I have to call an ambulance. That you will need to go to the hospital if we can't bring your blood pressure down to safe limit. And I can't ask you to go to emergency room with your car. I'll have to call ambulance. In New York, you can't afford to send the patient to emergency room with this kind of blood pressure. Remember, this is the first time I see her. So she goes on the second tirade of impressing me. No, my cardiologist, chief of cardiologists is Sinai, and my neurologist, chief of neurology at Columbia, and you don't know this. I let her ventilate, and after 2 minutes, I said, we have choice. You can either let us lower your blood pressure, or I call an ambulance. She goes into the third thing. So I let her go on, this time a little longer, and then I said, we have choice. Thanks. I'm going to step out, and I'm going to come back in 1 minute. And I want just an answer. Either you're going to let us help you lower your blood pressure, or you call an ambulance. You are a free citizen. You certainly can say no, but I'm obligated to call an ambulance. I will not have a preventable stroke on my conscience. And this is the first time I meet. So now, she forgot that she was a very forceful New Yorker. The bottom line is that her blood pressure came down to 170. I said, please don't go off your blood pressure medication on your own. First learn how to lower your blood pressure with breathing, with hydration, with these simple things. Then we'll help you gradually get rid of your medication. I estimated that we saved United States government from $50,000 to $75,000 by the miracle of breathing and not calling an ambulance. Now I want to give you a quick example, and then I think I have 2 more minutes left. I'll take one question. I get a call from Kings County. So the guy says, we have your patient that needs brain surgery as a tumor. And he says, no, I will not have surgery without Dr. Ali's clearance. And I said, I'm sorry, I can't help you. I don't know the case. I know he's hypertensive, but this comes as a shock to me. You have to do. And he says, but well, he just won't do it. Anyway, it's not a satisfactory communication. Next day, I get a call from another doctor, neurosurgery resident. Well, he needs surgery, and all our neurosurgeons agree that he needs surgery, but he's very obstinate, and he will not do it without you saying so. Well, I'm not in a position to tell someone not to have brain surgery who gets hospitalized for emergency thing. I don't know the details. So I said, well, I'm sorry, I can't really help you. Just talking to him on the phone, what can I say? I don't know the fact. So the bottom line, they said, okay, he's going to go to Mount Sinai. I'll cut it short. The guy comes in 4 or 5 days later. I asked them, is he stabilized? They said, yes. And they said it's pituitary tumor. So the guy comes in, and I'm trying to console him. It's not true brain surgery. They will go through this sphenoid sinus, and they will take out that thing. It's non-functioning pituitary adenoma, and you will be all right. And he's looking at me, and he's not satisfied. And I'm just, I don't know what I'm doing. So I said, okay, you're scheduled to have neurosurgical consult from Mount Sinai. Why don't we do that? I'm buying time, okay? Because I thought he needs this procedure. It's not as dangerous. To him, it's brain surgery. To me, it's not brain surgery. They're just going to go from outside and scoop it out. It's non-functioning. Well, as he goes out, I had this brain wave. I went out to the reception. I said, is he still here? They said, oh, he's going out hallway. I said, call him. The brain wave was, do you recall ever seeing a pituitary adenoma? See, pituitary adenoma, everyone knows in this audience, is in sella turcica, and I have never seen a patient where non-functional pituitary adenoma bled and created a crisis for which you will have a crisis brain emergency surgery or brain surgery. So I said, I've never seen that. What's the likelihood of that happening? So I said, call him. So he came in. I said, I am in a rush. I want you to write down everything that you did 3 days before you were hospitalized. Because the doctors told me he was hospitalized with confusion, encephalopathy type of picture, and hypertensive crisis, okay? Which meant that he has had a bleed. But I could not remember in all these years ever seeing a patient like that. So I called Dr. Fahmy. I said, Al, have you ever seen a patient who bled from pituitary adenoma, non-functioning, such that he needed emergency surgery? He said, no. I said, good. I called Dr. Juco. I said, Judy, do you recall a patient? She said, no. So when I saw him, I said, I'm in a rush and call, I want you to tell me. He said, Dr. Ali, I came from China. And I had a headache. And I went to the hospital. And they did an MRI. And they told me that I need surgery. Do you remember Dr. Francis Wakeman? Dr. Wakeman, one of the great Dr. Wakeman. When I think of a great doctor, I think of Dr. Wakeman. That's how much I think of him. Anyway, he was coming from Australia. They went to give some courses. In the way, he developed air travel dysox. In that oxygen book, there's a whole chapter where I call air travel dysoxygenosis. In other words, prolonged flight, all the requirements, many of these airlines, they actually put less, they take the fresh air into the engine and they take the recirculated air to the cabin, okay? And the same airline would use different models of planes, and they can change how much fresh air goes to engine because it saves them oil. So Dr. Wakeman developed air travel encephalopathy, and he never recovered from that. Okay. Then I had seen some patients who with prostate cancer, hepatitis C, who after air travel would develop serious problems. So I said, oh my God, this guy, that non-functioning pituitary adenoma is not the problem. So I said to him, now I can tell you because now I hear the inner voice, you don't need surgery. But I still want you to go to Mount Sinai. Okay? I want to see what they are saying. He went there, they told him they wanted to operate. This was several months ago. I saw him about a month ago. His blood pressure is under control, he doesn't have a headache, and there's no need. Now you tell me how much money has he saved United States government by not having. And I'll close on this. My conservative estimate is that if 80% of the surgery done in the United States was not done, people would be better off. Early cancer surgery, great. Trauma surgery, great. Thanks so much. I've really enjoyed being with you. And thank you for being here. Thank you.